Hi, my name is Juan Gonzalez, and I'll be telling you a bit about obsessive compulsive disorder. These are the objectives today. We're going to go through an introduction, etiology, DSM-5 criteria, signs and symptoms, OCD-related disorders, treatment, prevention, prognosis, and monitoring. A little bit about OCD. OCD is characterized by intrusive thoughts and compulsive ritualistic behaviors. OCD can be debilitating and can impact a person's quality of life negatively. Men usually have an early onset of OCD as opposed to women who tend to have an onset of symptoms early in adulthood. An interesting fact, according to American Family Physician, the average time it takes to receive treatment after meeting diagnostic criteria for OCD is 11 years. Getting into the etiology of OCD is unknown, but there are several theories. One is pediatric autoimmune neuropsychiatric disorder associated with streptococcal infections, also known as PANDAS. This affects children between the age of 3 and puberty. It is characterized by neurological abnormalities, but the cause is unclear. All we know is that it is associated with streptococcal infection. Another cause could possibly be stimulant-induced. Again, the reason why is uncertain, but stimulants have been known to worsen symptoms. The last theory is that serotonin and dopamine play a role in OCD since antagonizing these hormones have been effective in improving symptoms. For the DSM-5 criteria, OCD is split into obsessions and compulsions. To be diagnosed with OCD, you must meet both criteria for either obsession or compulsions. For obsessions are recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. The second part is the individual's attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. Compulsions, you must meet both of these, which are repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety, distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent or are clearly excessive. For signs and symptoms, we can categorize obsessions and pair them with compulsive behaviors. Like an aggressive obsession can be the fear of harming others, and the compulsive behavior can be looking for validation that you're a good person. An obsession with contamination is being a germaphobe or simply just fear of being contaminated, and the compulsive response is excessive cleaning. Pathological doubt is excessive worrying, and the compulsive response would be excessive checking the correctiveness of your work. Religious obsession can be sinful thoughts, and the compulsive response could be excessive praying and asking for forgiveness, and so on. The point being that the obsession and compulsion affects the quality of life and can become detrimental. There are also several OCD disorders that we see here. There is body dysmorphia, where a person perceives that their appearance, they perceive flaws in their appearance, which can lead to unhealthy behaviors to change their appearance. Excoriation disorder is skin picking that leads to lesions. Hoarding disorder is difficulty in discarding possessions that stem from a strong urge to save them and can cause stress with the people attempting to discard them. And finally, trichotillomania is the recurrent hair pulling and plucking resulting in hair loss. In these pictures, we have some few examples of how they can become detrimental to a person's health. Back to this, a way to help these people can be behavioral therapies or habit reversal therapies, and very little evidence shows that pharmacotherapy actually helps with these. Um, Here we see a treatment triage, as we see on the side over here, the first line, second line, third line, and I will explain them here. we first start with assessing the severity of OCD. If severe, we can start patient on right away on an SSRI with or without cognitive behavioral therapy. If um, the severity of OCD is mild to moderate, we can either start them straight with the SSRI with or without cognitive behavioral therapy, or we could take the just cognitive behavioral therapy approach right away. If satisfactory, we continue till we finish the course, and we could have periodic booster sessions. If unsatisfactory, we move on to the SRI with or without CBT. Um, and depending on the outcome of this, if satisfactory, we'll just continue the medication for at least 1 or 2 years or indefinitely in most cases. If unsatisfactory, we move on to our second line therapies, which is we switch to a different SSRI and we continue cognitive behavioral therapy. If satisfactory, same thing, we continue for 1 or 2 years or indefinitely. If unsatisfactory, we move on to our third line therapy, which is either to switch to clomipramine, augment with SSRI therapy, and augment SSRI with an antipsychotic, and that'd be it. Moving on, for the SSRIs, here we have our FDA-approved SSRIs for OCD, which are escitalopram, citalopram, paroxetine, sertraline, fluoxetine, and fluvoxamine. SSRIs inhibit the reuptake of serotonin by inhibiting the serotonin transporter at the presynaptic axon terminal, thereby increasing serotonin activity. Common side effects are nausea, vomiting, diarrhea, headache, drowsiness. More serious side effects would be insomnia, appetite changes, and sexual problems. But most importantly, serotonin syndrome. SSRIs are contraindicated in MAOI therapies or concomitant use with MAOIs, and they carry a black box warning for suicidal ideations. Clomipramine is a tricyclic antidepressant. It acts as a serotonin reuptake inhibitor with a strong affinity for serotonin transporter. Clomipramine has the same efficacy, but with less tolerable side effects. Clomipramine is contraindicated in myocardial infarction, MAOI therapy, and in patients who are hypersensitive to tricyclic antidepressants. These also carry a black box warning for suicidal ideations and are very important. And it's very important to monitor LFTs and baseline ECGs. Finally, the antipsychotics. We have Abilify and risperidone. Antipsychotics are most known for their dopamine antagonism, but for OCD, antipsychotics are used because they also block serotonin at the serotonin 2A receptor. Here, common side effects are weight gain, metabolic changes, and sedation. More serious side effects are extrapyramidal symptoms, which can be anything from dystonia, akathisia, and Parkinsonian symptoms. For prevention, since the etiology is unknown, we don't really have a way to prevent it, but early diagnosis and treatment can be very effective if we could start the treatment sooner. As we said, that little fun fact that it takes about 11 years. So if we get on it before it becomes worse, it will be better. Since OCD is a long-lasting disorder, ongoing treatment is necessary. We can hope that over time a patient slowly recovers from OCD, but this disorder can be lifelong. We can monitor treatment during follow-ups, ask the patient how they're feeling, as well as monitor their LFTs and baseline ECGs. During follow-ups, we can fill out a Yale-Brown obsessive-compulsive scale, which can determine the severity of the patients. This scale comes from, well, the white box is a questionnaire, which assesses the severity of OCD. And follow-up visits are recommended at least for the first 3 to 6 months. In conclusion, we know that OCD is a debilitating disorder. The etiology is unknown. First-line therapy is CBT or an SSRI. We need to monitor the LFTs and baseline ECGs. And OCD is lifelong, but is manageable for most people. Thank you. This is my reference page.